Let's talk hyperventilation. Hyperventilation syndrome is very common, is easily recognized, and it is just a condition in which your patient's just breathing too fast for no other reason than they are breathing a little bit too fast. So, in hyperventilation syndrome, our minute ventilation exceeds our metabolic demands. So, we're blowing off a lot of CO2 and our metabolic demands, we're just not producing as much CO2 as needed that we're blowing off. We're not using enough oxygen that we're breathing in. So we are breathing very quickly for no other reason than that we are breathing very quickly. But we have to be careful. We have to be very careful before just labeling our patient as hyperventilation syndrome. And just saying you're just breathing too fast, stop it. Right? There are a lot of mimics to hyperventilation syndrome. So hyperventilation syndrome is just we're breathing too fast because we're breathing too fast, and no underlying condition therein. Our mimics, we're breathing too fast because there is a reason. So we need to rule all of these out before we go into this hyperventilation syndrome diagnosis. So, myocardial infarction, they might be breathing a little fast. Pneumothorax, whether simple or tension or hemo, might be breathing a little fast. Pulmonary embolisms are going to cause us to breathe a little fast. Congestive heart failure are going to cause us to breathe a little fast. Any of our metabolic acidoses, DKA, or diabetic ketoacidosis, can cause us to breathe too fast. That doesn't mean that we're just, hyperventilation syndrome. That doesn't mean that we're just breathing too fast just to breathe too fast. That means we're breathing too fast to compensate for something. So we need to rule out these mimics before we go into this differential diagnosis of just simple hyperventilation. So when will our patients present with hyperventilation? Well, about 50% of our anxiety attack patients. So just be aware that most of our anxiety attack patients, they might not be hyperventilating. So about 50-50, our anxiety or panic attack patients will be hyperventilating. Some of our chest pain patients will be hyperventilating. Like we said, our DKA patients will definitely be hyperventilating. This isn't an issue of hyperventilation. This is an issue of compensation. If we think back to our acid base, they're trying to compensate for that metabolic acidosis by blowing off carbon dioxide. So sometimes patients are hyperventilating for a compensation reason. Sometimes they're hyperventilating for in response to pain with our chest pain patients. Sometimes they're hyperventilating because of anxiety or panic attack. Some signs and symptoms with this hyperventilation syndrome. Obviously, our patient's going to be breathing a little bit fast. If we put them on capnography, we're going to see a low CO2 because they're blowing off lots of CO2. We need to figure out why they're blowing off lots of CO2. We need to figure out why they are hyperventilating. But they might have some confusion because they're blowing off a lot of CO2. It's going to make them a little lightheaded, right? With our hyperventilation syndrome patients, they're going to have clear lung sounds. There's going to be nothing wrong with their lung sounds. They're not going to be rhonchorous. They're not going to be fluid-filled. They're not going to have any wheezing. They're not going to be any stridor. You're going to listen to the lung sounds. They're going to be completely clear, but they're still going to be breathing a little bit fast, right? And then you might see some carpopedal spasms, some paresthesia, that kind of tingling, pins and needles sensation on their skin, that carpopedal spasm. Remember, with hyperventilation, there's a hypocarbia effect to that. They're blowing off a lot of CO2. There's going to be a calcium shift with that, and they're going to experience some carpopedal spasms along with that. If we were to pull some ABGs for a simple hyperventilation patient, they'd have a normal PO2 because we're moving oxygen just fine. We are unloading oxygens onto hemoglobins just fine, so our O2 is just fine. Our CO2 is going to be super low because we're blowing off a lot of CO2. We're breathing just way too fast, blowing off a lot of CO2. So O2 is fine, CO2 is low, so we're going to be in a respiratory alkalosis because remember when our CO2 goes low, our pH goes high. Our CO2 and our pH move in opposite directions, so CO2 goes low, pH goes high, but this is an acute state, so most people just don't hyperventilate every single day, every hour of every day. So this is an acute state, and our kidneys take a little while to accommodate for that, just for that. So our PCO2 is low, meaning our pH is high. But if we looked at our bicarb or HCO3, that's going to be normal. Because we're in an acute state, we are uncompensated. Now you've recognized your hyperventilation syndrome patient. It's not due to anything else, it's just hyperventilation. So what do? We could stick a paper bag on their face and say, breathe into this paper bag. Don't do that. Ever. Never. Don't do that. Right? So why don't we just give them a paper bag? Let them rebreathe. So the idea behind that is let them rebreathe the CO2 that they are breathing off. So it's a respiratory alkalosis. So let's readjust their CO2 levels. Well, what if we're wrong, right? What if they're actually in DKA and they should be breathing off all of this CO2? Well, we just put a paper bag over their face, or we put a non-rebreather on their face and didn't turn on any oxygen. What if we did that and they're actually in DKA, or they're actually in some metabolic acidosis? Maybe they, downed a bottle of aspirin and didn't tell us. What if? Well, we just took away their compensatory mechanism, and they're gonna tank on us. So that paper bag method, in quotes, right, air quotes, that paper bag method is contraindicated. Do not do that, just in case it's something else. Just in case you're wrong, that it's just not a simple hyperventilation syndrome. Do not do that. If you think it's hyperventilation, if you think it's anxiety, we can talk them down. And we can put them on oxygen. We can put them on a little bit of oxygen, make them feel better. Right? You think it's a panic attack, you think it's an anxiety patient, we can try to talk them down. Put them on a nasal cannula. Do a very thorough patient assessment. Because all of our metabolic acidoses, remember that mud pile's pneumonic? Let's rule all of those out. Let's try to get through all of those. If you still think it's hyperventilation, let's just try to talk them down, put them on a little bit of oxygen, and make them feel better. When all else fails, and you're definitely dealing with a hyperventilation syndrome, an isolated hyperventilation syndrome patient, we can go to chemical sedation. We can think about our benzodiazepines. We can think about Ativan, think about Valium, Versed, maybe Haldol, depending on the situation, but we can think about chemical sedation. Remember, you're going to have the protocols for this because chemical sedation is a restraint, is a chemical restraint, is a drug restraint, and we need to take it as seriously as we do physical restraints. So if we are going through our protocols for physical restraints, this is the same as a physical restraint, it's just chemical. So if you know it's just a simple isolated hyperventilation syndrome and you need to restrain a patient, think about chemical restraints the same way you would physical restraints. If you have any questions, comments, concerns, or cuss words, please let me know.